Hello everyone, today my topic of discussion is epinephrine reversal, which is from the autonomic nervous system. So if you like my videos, please subscribe my channels and give me a thumbs up. So before understanding the epinephrine reversal, you have to understand that the epinephrine is stimulated which one receptor and norepinephrine is stimulated which one receptor, right? Or they are acted upon by which one receptor, they are acted on which one receptor. So the first slide I'm going to show you that epinephrine, it is acting on which one receptor and norepinephrine is acted on which one receptor. So epinephrine is acted on the stimulated the alpha 1 receptor, alpha 2 receptor, beta 1 and beta 2. So all four adrenergic receptor, they are particularly activated by the epinephrine. But norepinephrine, it is activated the alpha 1, alpha 2 and beta 1. Now you can see the beta 2 is missing. So norepinephrine is not stimulating the beta 2 receptor. Then you can be asked by a question that why norepinephrine not act on the beta 2 receptor. So the answer is because beta 2 receptor are not innervated on the vessels. So that is the answer of the questions. So now you understand first thing that epinephrine acted are stimulated alpha 1, alpha 2, beta 1, beta 2 receptor, while the norepinephrine activated alpha 1, alpha 2 and beta 1, not the beta 2 receptor. Now I will tell you in the next slide where these receptors are located. So beta 1 on the heart you have beta 1 receptor and M2 receptor, which is your cholinergic receptor, right? So whenever beta 1 on the heart is stimulated, either by the beta 1 agonist drugs or through the sympathetic autonomic nervous system, it will result in increased heart rate. Similarly, M2 receptor is the cholinergic receptor. Whenever it is stimulated by the M2 agonist drug, not M2, particularly muscarinic agonist drug, it will result in decreased heart rate. The second way the M2 is activated is the para-autonomic nervous system. So whenever these receptors are activated by beta 1, if it is stimulated by the sympathetic autonomic nervous system, it results in increased heart rate, which is called reflex tachycardia. And if para-autonomic nervous system stimulate the M2 receptor, it will result in decreased heart rate, which will result in the reflex bradycardia. That's why on the side note I have written these stimulation will result in reflex brady and the reflex tachycardia, right? Now on the vessels, so this I have made the vessels. On the vessels you have three receptor, alpha 1, beta 2, M3. I have given a mnemonic way that you can remember A, B, C. So A, B, C are the receptor. A for alpha, so I'm writing over here A, B, C. So you have to remember like alpha, A, B, beta. So 1, 2, and by C you can remember that it is M3, and 3 is your letter C. If you can remember. In this session, I'm not talking about the muscarinic or cholinergic receptor. I'm just focusing on the alpha 1, alpha 2 receptor. Okay, let's start it for this slide. That you see this is a vessel. On the vessel you have alpha 1, beta 2 and M3 receptor. Alpha 1 is innervated. This yellow line, it is showing that the alpha 1 receptor is innervated, while the beta 2 receptor on the vessel is not innervated. That is the reason that norepinephrine cannot stimulate the beta 2 on the vessels, whereas the epinephrine can stimulate alpha 1 and beta 2 also. So what is happening if you are stimulating the alpha 1 receptor, right? So you will result vasoconstriction. Whenever you do the vasoconstriction, so what will be the result? You have increased the total peripheral resistance, and that will result in the increased blood pressure. So whenever you have increased blood pressure, the effect on the heart will be opposite. That if you have increased blood pressure, the heart rate will be decreased. If you have decreased blood pressure, the heart rate will be increased, right? So now in this case, if you have remember that I have stimulated alpha 1 receptor, that result in vasoconstriction, that increase my total peripheral resistance, my blood pressure will be increased. So now what would be the effect on the heart? You see over here, by increasing the blood pressure, the heart rate will be go down. So what is happening? When you are increase the total peripheral resistance, increase the blood pressure, the baroreceptor reflex is activated. It go to the para-autonomic nervous system, stimulate the M2 receptor, and you decrease the heart rate, which is called the reflex bradycardia, right? So now coming back, if you are stimulating the beta 2 receptor, which causes the vasodilation, right? Vasodilation. And let's say epinephrine is coming and stimulated beta 2 receptor, it causes vasodilation, it results in Decreased total peripheral resistance, which will result in decreased BP. So when you are decreasing the total peripheral resistance, blood pressure will be decreased. So what will be the happening on the heart? Your heart rate will be increased. So what is happening whenever the BP will be decreased, baroreceptor reflex will be stimulated. It go on the heart to the autonomic, sympathetic autonomic nervous system. It stimulate the beta 1 receptor, and that will be result in increased heart rate. That is called reflex tachycardia, right? So this is how these receptors are acting and doing the brady and the reflex tachycardia and how it is stimulated. Uh, Let me tell you again that norepinephrine is not stimulated beta 2 receptor, it is not innervated, right? So by solving these kinds of twisting, you have to remember you should start with the total peripheral resistance and end with the heart rate. Let's say they give you these kinds of twisting. So what you have to remember on these twisting, I will explain 2 to 3 points on these twisting. That this is your systolic blood pressure, upstroke. This downstroke are showing the diastolic blood pressure, and this medium line is showing your mean arterial pressure. So you have to see the mean arterial pressure in this case. So if mean arterial pressure will be go up, you are dealing with the increased blood pressure. You can say you have the alpha 1 or the vasoconstriction, or you have total peripheral resistance. Your total peripheral resistance is increased, that by mean arterial pressure will be increased. Now about these lines, these traces. So if these traces are pretty much close like this, then they are showing the reflex tachycardia. But if these traces go like this, then you can say these are the reflex bradycardia. That is the distance between these two. Traces are the troughs, you can say, right? So if the distance is increased, you have bradycardia. If the distance is decreased, as you can see over here, then it is tachycardia, right? So that is the two things you have to remember over here in this twisting. Just I am explaining you that this is showing the phenylephrine. Phenylephrine is a purely alpha 1 agonist. When it is stimulated, it causes increase of the mean arterial pressure. So when mean arterial pressure will be increased, so what will be happen? The heart baroreceptor reflex is stimulated, so that will go and stimulate the paraautonomic nervous system, and that stimulate the M2 receptor on the heart, which will release reflex bradycardia. That's why you see the distance between these troughs are, these trace will be increased. Alpha 1 increase the total peripheral resistance, increase blood pressure, and you are potentially having the reflex bradycardia, right? So that is how they are telling you. So the 2-3 things you have to remember by if they given you these kinds of twisting, you have to start with the total peripheral resistance and the blood pressure, and you have to end on the heart rate. If BP will be increased, heart rate will be go down. If BP will be decreased, heart rate will be go up. So this is how you can remember, and these tracings are showing this way. Now the next slide, what is showing? So in the next slide, I am showing you how these tracing are happening in case of the norepinephrine and the epinephrine. For norepinephrine, as I told you, it is alpha 1, alpha 2 and beta 1. Alpha 2 are particularly located on the on your presynaptic vessels, right, which I explained you. Let's say this is your presynaptic nerve terminal, right? Over here your alpha 2 receptors are located, which is the autoreceptor. This is postsynaptic neurons. So whenever norepinephrine is in the cleft, it is increases, it go and stimulated these receptors, and these receptors alpha 2, these are inhibitory receptors. So what, when they are stimulated, they decrease the cyclic AMP. So when cyclic AMP will be go down, so what will be happen? These calcium channels, they will be shut down. No calcium entry inside the terminal, so no norepinephrine will be stimulated. So alpha 2, as they are located on the presynaptic terminal, that's why these tracing, they will not show the alpha 2 response. So I am excluding this one. You will not see on the tracing alpha 2 response. So focus on the norepinephrine is acting on the alpha 1 and the beta 1. So what is happening? Let's say this is the normal trace of the patient, and you give the norepinephrine. So norepinephrine acting on the alpha 1 receptor. As I told you, you have to start with the vessels. So total peripheral resistance will be increased, blood pressure will be increased. So my mean arterial pressure line will be go up, right? So then what is happening? Beta 1 receptor is stimulated, as the norepinephrine is acting on the alpha 1 and beta 2. When beta 1 receptors are directly stimulated by the drug or norepinephrine, which is your neurotransmitter, the heart rate will be go increase by this. Heart rate will be increased. So what is happening? When your heart rate will be increased, now your baroreceptor reflex will be stimulated, because you have the increased blood pressure along with the increased heart rate. So baroreceptor reflex will be initiated and it will be result in the reflex bradycardia. This is the specific tracing you can see in case of the norepinephrine. Like alpha 1 stimulation increase the mean arterial pressure, then beta 1 stimulation it causes the increased heart rate, and then you have reflex bradycardia because of the baroreceptor stimulation, and that reflex bradycardia is the long term. So in this case you can say that your vessels are win over the heart. Why? Because the total peripheral resistance is basically controlling the heart rate, not the beta 1 direct effect. So over here this green line, they are saying the net effect on the heart rate is increased initially, followed by the long term decrease, which is your reflex bradycardia. And this point, this is showing there is a no effect of beta 2 on the beta 2 effect by the norepinephrine. One other thing you have to remember, that if I am using the atropine before giving the norepinephrine, the same tracing, let's say this is your patient, so before giving the norepinephrine I give the patient atropine. So what is atropine? So atropine is your muscarinic antagonist, right? Muscarinic antagonist. As you know that this reflex bradycardia, it is mediated by the M2 receptor on the heart, right? M2 receptor on the heart. So when you're giving the atropine, you are basically blocking the muscarinic receptor on the heart, M2 receptor on the heart. So in that case, you will not see this reflex bradycardia. Your strip will be continuously like this. This is very important point. And other thing you have to remember, which is ganglion blocker. Ganglion blocker is also diminish the reflex brady and the tachycardia. So in case of atropine or the ganglion blocker, which is your hexamethonium and mecalamine, both of those drugs also prevent the reflex brady and the tachycardia, and your strips will be not changed. These are the extra points I explain in my first aid session, where I am reading the first aid with you guys. You can see over there those session and you can repeat that concept again. So now coming toward the norepinephrine. So epinephrine is very interesting drug, because a very interesting neurotransmitter. As I told you, it is acting on the alpha 1, alpha 2, beta 1 and beta 2 or receptor. So what is happening? Epinephrine is coming in 3 doses. At low doses, it is exactly behave like a isoproterenol. So isoproterenol is what? Isoproterenol is your beta agonist, which is acting beta 1 and beta 2 same. So it has same beta 1 and beta 2 effect. So you can say in case of low epinephrine, so epinephrine behave more like have more beta effect rather than the alpha effect. So epinephrine in case of low dose have more beta effect than alpha effect, low dose epi. So I'm writing over here also, so you don't be confused. So what is happening in case of low dose, you know that the beta effect will be more. So what is happening? Epinephrine, when you're giving in the low dose on the vessels, it stimulates the beta 2 receptor, not the alpha 1. As I said, beta effects are more with the low dose epinephrine. When beta 2 receptor are stimulated, they cause vasodilation. Vasodilation decreases total peripheral resistance, and decrease blood pressure. You over here you will see the strips. When you're giving the low dose of epinephrine, the blood pressure, mean arterial pressure will be go down, right? Now they are introducing the beta 1 effect, right? They are directing on the direct effect on the B1 receptor, beta 1 receptor on the heart, because low dose epinephrine have more beta effect. So beta 2 decrease the blood pressure, while the beta 1 effect increase the heart rate. So this is the same strip you will see in case of isoproterenol, which have the beta 2 and the beta 1 effect agonist, right? So next is your medium dose. So in case of medium dose epinephrine, this is a little bit tricky and not usually used. Why it is not used? Because in medium dose of epinephrine, your alpha effects are equal to the beta effects. Both effect will be similar. So in case of vessels, if epinephrine is stimulating, I'm making the vessels again. So in case of medium dose epinephrine, so if epinephrine is stimulated alpha 1 receptor, it increase the blood pressure by increasing the total peripheral resistance. But at the same time, epinephrine medium dose stimulated the beta 2 receptor and decrease the blood pressure by decreasing the total peripheral resistance. So decreasing total peripheral resistance or increasing total peripheral resistance, they cancel each other effect. So what would be the net effect? So net effect, your mean arterial pressure will be remain same. So these lines which are becoming wide increase in length, so this is due to the increased heart rate, beta 1 effect. So heart rate will be increased, they are congested, but their widths will be increased. As increased heart rate will be increased the stroke volume and the increased cardiac output, but overall mean arterial pressure will be remain same, but the heart rate will be increased. right? And the pulse pressure will be also increased. Now the low dose epinephrine, because this is very important. Sorry, not the low dose, high dose of epinephrine. This is very important. So that's I have to rub all this so you can clearly understand the high dose of epinephrine, how this is effect. I told you about the medium dose of epinephrine. I told you about the low dose of epinephrine. Now coming to the high dose of epinephrine. So epinephrine on the high dose is always acting or behave like a norepinephrine. So now you can see the strip. Let me go back to the strip of the norepinephrine. Here you can see when you give the norepinephrine, this is the strips look like. So now coming over here, you see the strips of the epinephrine high dose. It's behaved similarly like the norepinephrine. So now you have to differentiate it that this strip is due to the epinephrine or the norepinephrine, and that is basically called the epinephrine reversal. So first we will go with the high dose epinephrine. So high dose epinephrine is doing what? High dose epinephrine have more alpha effect than beta effect. It has the beta effect, but the alpha effects are more pronounced. So on the vessels you have alpha 1, beta 2. So high dose epinephrine stimulate the alpha 1 receptor. So what it does, it increase the total peripheral resistance and increase your blood pressure. So what is this will be tracing? Your mean arterial pressure will be go up, right? Now what will be happen? They stimulate first beta 1 receptor. So what will be happening? You have increased heart rate, right? Tachycardia, increased heart rate, which is your tachycardia. So what will be happening? So when this tachycardia is so pronounced, then what would be happen? There will be stimulation of the baroreceptor reflex, and you will stimulate the M2 receptor on the heart rate, and you will produce the reflex bradycardia. So this is how the strip will be look like. These beta 2 effect will be less pronounced compared to the beta 1 effect when you are using the high dose of the epinephrine. Now you have to tell that it is high. How you can differentiate, because when these kinds of graphs are the things given in your real test, they will ask you the question. You have to tell which one is the drug, high dose epinephrine or non-epinephrine. They put those thing and they will ask you how you differentiate. So that is the concept of the epinephrine reversal. So let's say this is your epinephrine and this is your norepinephrine, right? As I told you that the epinephrine in high dose behave like a norepinephrine. So what will be happening when you give the high dose of epinephrine? Let's say this is the mean arterial pressure. Your arterial pressure will be rising up, right? Rising up. Then what will be happen? It stimulate the beta 1 receptor and result in the tachycardia, right? Similarly, you give the patient norepinephrine. So what will be happen? This is the mean arterial pressure. Now your mean arterial pressure will be increased by both are acting on the alpha 1 receptor, increased total peripheral resistance, increased blood pressure. So mean arterial pressure will be rises up in case of both norepinephrine and the epinephrine, right? So now how you can differentiate that the graph is by the epinephrine and norepinephrine? You use the alpha 1 blocker, right? So when you are using the alpha 1 blocker, you are basically cutting down the effect of alpha 1. So let's say in case of norepinephrine, so before giving the norepinephrine over here, this is norepinephrine I give to the patient. I give the patient alpha blocker. So what will be the blood pressure now? You are cut down the effect of alpha 1. So what would be happen? Now the blood pressure in case of norepinephrine will be stay the same. So this is the mean arterial pressure when you're using the alpha 1 blocker, right? Arterial pressure will be remain the same because you have cut down the alpha 1 effect and the norepinephrine is not acting on the beta 2. So mean arterial pressure will be remain the same. Now what will happen over here if you give the high dose of epinephrine, right? So this will be the effect, alpha 1 effect, increase the blood pressure. Now you are giving same alpha 1 blocker to the patient who have given epinephrine high dose. So what will be the effect? Now in this case, when you are cutting down the alpha 1 effect, the blood pressure of the epinephrine will not remain the same. What will be happen? It will drop down. So you see why it is dropped down? Why? Because epinephrine can act on the beta 2 receptor. So what is happening on the vessels? You have alpha 1, you have beta 2 receptor. So when you cut down the alpha 1 receptor for epinephrine, so epinephrine is saying, okay, no problem. If you are knocked down the alpha 1 receptor, I can stimulate the beta 2 receptor. So it will go and decrease the blood pressure, like from the hypertension by having the increased mean arterial pressure, it is now producing the decreased mean arterial pressure, and that is called the epinephrine reversal, right? This is called the epinephrine reversal. However, norepinephrine, it is not acting on the beta 2 receptor. So when you ever block the alpha 1 receptor, the mean arterial pressure become a steady line. It is not increasing, not decreasing, and that is the reverse case of the epinephrine. So however, here you can see the slight differentiation of the high dose epinephrine, norepinephrine. So epinephrine reversal, use of alpha 1 blocker to reverse the hypertension to hypotension in a patient receiving too much epinephrine, that is high dose of epinephrine. Hypertension was due to the predominant alpha 1 tone on the vasculature, when hypotension is due to the unmasking, because by giving the alpha 1 blocker you are not blocking the beta 2 receptor activation. So epinephrine act on the beta 2 and decrease the blood pressure. That is the bottom line. And on the graph, this is giving on your book how the graph will be look like. This is the same thing. If you pay attention, unopposed alpha 1 stimulation in case of norepinephrine will increase the blood pressure and you will have the reflex bradycardia. In this case, they have using the low dose of epinephrine. That's why they're telling you about the beta 2 stimulation decrease the vasodilation and decrease the blood pressure. And what will be happen if you decreasing the blood pressure? You have increasing the beta 1 effect, which is also direct beta 1 effect by low dose of epinephrine, or will be the reflex tachycardia. Thank you so much. Hope this video will be help you out. Please give me thumbs up. Thank you. Bye.